Hi, everyone. Welcome to the e-journal presentation for today, December 20th, 2023. As we present our feature peer-reviewed journal article of interest today, we're also joined by the distinguished senior author of the article. This unique, interactive, and engaging experience will give you, our audience, the opportunities to interact and discuss methodologies, insights, and findings directly from the source with our author. We would love to hear from you, the cytopathology audience, your thoughts, questions, and reflections on the general topic of HPV and or high-risk HPV negative pap tests. You can share your comments and thoughts with us in the chat box. We will periodically be monitoring the chat box. There will also be time at the end of the presentation to address many of your questions and comments. The feature article for today is the significant outcome associated with high-risk HPV negative pap test, and was written by Dr. Selda, Karaaslan, Thomas Dilcher, Mary Abdelsayed, and Dr. Abha Goyal. I'm delighted to say that we are able to have the senior and corresponding author of the manuscript with us today to discuss this article. I'm Dr. Paul Chiou. I'm the faculty and education coordinator for the MS Diagnostic Cytology program here at Rutgers University, New Jersey. While we may be very familiar with our author, I would still like to introduce her. Dr. Abha Goyal is the Associate Professor of Clinical Pathology and Laboratory Medicine at Weill Cornell Medical College. She is the Associate Attending Pathologist at New York Presbyterian Hospital. She is the member of College of American Pathologists, Cytopathology Committee, and American Society of Cytopathology Clinical Practice Committee. She is also on both the editorial boards of Journal of the American Society of Cytopathology, as well as Diagnostic Cytopathology. So the objective of today is to discuss the study significant outcomes associated with high-risk HPV negative pap test in the context of cervical cancer screening and guidelines. In this interactive presentation, we would like to review the evolution of cervical cancer evaluation, specifically the emergence of the use of HPV testing in cervical cancer screening. We will also discuss the main article, of course, the significant outcome associated with high-risk HPV negative pap tests, including the key factors that make this novel study different than other papers that have explored the role of cytology in the detection of HPV negative lesions in the past. Finally, we will also ask the author to share with us her thoughts on the implementation of cervical cancer screening in the future. What, in her opinion, are the main issues that should be considered? Of course, also her thoughts on the role of both pap testing and HPV screening in that paradigm. First, let's take a step back and briefly summarize where we've been in cervical cancer screening. So Dr. Swid and Monaco wrote a fascinating piece in Modern Pathology last year, looking back at the history and evolution on the use of HPV testing in cervical cancer screening. In that review article, the authors talked about the development of cervical cancer screening. Of course, this all started with Dr. Papanicolaou's discovery in the 1920s that abnormal cervical cells can be found on smears with a microscope. Dr. Papanicolaou and Dr. Herbert's seminal publication in the 1940s improved our understanding of the morphological changes in the cervical mucosa and paved the way for establishing pap screening tests as a successful cancer screening test. The pap test was associated with significant decline in cervical cancer-related death from 1940 to today. 40 years after the initial publication of the pap test, the next big breakthrough in the field was made when HPV was discovered in the 1980s. It was discovered as a causative agent of many of the cervical cancers observed. HPV testing started as a reflex test for indeterminate ASCP cases upon its approval by the FDA in 1999. Co-testing or cervical cancer screening with the use of both cytology and HPV testing together became approved and recommended around 2004. In fact, the 2012 guideline from the ACS, ASCCP, and the ASCP all favor co-testing as a primary method for women who are 30 years and older because of the increased reassurance of a double negative test. Between 2018 and 2019, the U.S. Preventive Service Task Force recommended that women between 30 to 65 years of age to be screened using one of the three methods you see here in the green bracket. That is the number one, cytology every 3 years, or high-risk HPV every 5 years, or co-testing every 5 years. In 2020, however, more divergent guideline emerged, with the American Cancer Society updating its guideline preferring the HPV testing for primary screening instead of the recommendation made by the U.S. Preventive Service Task Force noted above. This brings us to the feature article, which uses not only cytology and HPV results, but also histologic follow-up, as well as past history and clinical presentation of the patients in providing insights for future screening guidelines. Before jumping in and dissecting the study, I'd like to ask Dr. Goyal on what inspired the study. People, especially those of our viewers working in academia, are always interested on how others got inspired for their projects, in the hope that we can also improve our own creative process. So Dr. Goyal, where did the idea for the study originate?
First of all, I would like to thank you, Paul, and the internal committee for inviting me to this webinar and giving me the opportunity to discuss this study. So I thought about this study somewhere around late 2020. And I believe that it was in July of 2020 that the American Cancer Society guidelines were published. And these guidelines, they put forward primary HPV screening as the preferred strategy for cervical cancer screening in women 25 years of age or above. And this guideline created some sort of excitement and some uproar in the cytopathology community. And now you have to understand, a lot of time has passed since then. But at that time, there were a number of publications which were investigating co-testing versus HPV testing alone for the purposes of detection of high SIL or worse. And I thought that this would be a right time to investigate the role of cytology independent of the HPV test in detection of significant abnormalities at our institution. So it seems like, you know, the situation was kind of ripe to go ahead and embark on this study.
Absolutely, absolutely. Let me move on to the next slide. Another question that is important to ask and for our audience to know is how this study is different from other HPV-related publications that have investigated the role of cytology in detection of cervical cancer. For example, Dr. Blade and her colleague from the commercial lab published her investigative of various cervical cancer screening options in the journal Cancer Cytopathology. Their studies show that co-testing was more sensitive at 98.8% sensitivity compared to HPV testing alone at 94% sensitivity in women ages 30 through 65 with CIN3 or worse. And Dr. Ashman and her colleagues also conducted a similar retrospective study highlighting the role of cytology in enhancing the sensitivity of the co-test in the detection of cervical cancer. So Dr. Goyal, how is this study different from these other studies?
So, you know, when I decided to pursue this study, I did do a thorough review of literature to understand, you know, how I could improve upon or contribute further to the literature. And what I figured was that most of these studies, which are very significant in their own regard, they were focusing on HPV-associated squamous lesions, specifically high-grade squamous intraepithelial lesions or cervical carcinomas, which are typically HPV-associated. And the other thing was that a lot of these studies were not looking at the past history or the clinical presentation of the patient. So what I thought is, in order to make this a more comprehensive study, I decided to include the lesions which are HPV independent as well, but they could be detected by cytology. And the other thing that I focused on was trying to elucidate the role of cytology in the clinical context. So we also dug deep into the electronic medical record to look at the past history of the patient. And we went as far as back the medical record took us. So we just didn't, focus on the last 1 year. We looked at all the past history that was available to us, and we also looked at the clinical presentation of the patient. So we were trying to understand the role of cytology in the context of all the information that may be available to us.
That's certainly a very, very unique perspective and contribution. Now, Dr. Goh, this article has a lot of very interesting results. For instance, you look at the distribution of the HPV negative cases across different Pap test categories depicted in this table here. Can you tell us a little bit about how these data were collected?
Right, I think the data collection aspect of the study was the most challenging task. And I would like to acknowledge my co-authors here, who did a tremendous job regarding that. So first of all, the study was for a period of little over 9 years. So we looked at all the Pap tests which were examined at our lab. And then we filtered out all those interpretations which may result in histologic follow-up regardless of the HPV test result, as per the current ASCP guidelines. So we had to kind of go and look at this data at a very granular level and filter these interpretations. So that would include all carcinomas, whether squamous, adeno, high cell suspicious for invasion, ASCP, LCLH, and all the categories and subcategories of glandular cell abnormalities. So first we had to look at all those cases, then we had to figure out how many of these were tested for HPV. And out of those, how many were HPV negative? And ultimately, we came up with a study cohort of 763 cases. We had to filter out patients who had repeated Pap tests during that period. And then we had to see how many of these 763 patients had histologic follow-up within 1 year of that Pap test. So so this was a tremendous task, and I just went over the steps that we had to go through.
Thank you. Thank you for walking us through the data collection process. Certainly a very, very tremendous effort. So this upcoming question is really about major findings in the study. So during the study period, a lot of Pap tests were examined at your laboratory. I believe something like 345,000 Pap tests were examined, and many of them were HPV co-testing with HPV co-testing. And in the paper, you discuss your findings by breaking them down into 4 separate categories. Number 1 is a histologic follow-up of squamous cell abnormalities, and then you have the histologic follow-up of glandular cell abnormality, and then the clinical history of patients with HPV-associated lesion on follow-up, as well as final category of clinical history of patients with HPV independent or unassociated lesion on biopsy follow-up. Dr. Goyal, can you go over the findings for each of these categories with us?
Yes, sure. So, as I said, ultimately we looked at all those HPV negative interpretations that were associated with histologic follow-up within 1 year of that Pap test. So, as Paul mentioned, we subdivided them into squamous cell abnormalities and glandular cell abnormalities. So interestingly, now you have to remember these are all HPV negative cases. So of the squamous lesions, which were 289 and which had follow-up, around 18% had high SIL or worse. And most of these were associated with high SIL. We only had 2 cases of actually documented metastatic squamous cell carcinomas. Moving on to the next slide. So on the other hand, if you look at the glandular cell abnormalities, most of these were associated with endometrial carcinomas on follow-up. And you can see that we only had 3 adenocarcinomas in our cohort. So most of these were being categorized as atypical endometrial cells or atypical glandular cells. And one tries to understand, why they were not classified outright as endometrial carcinomas. Interestingly, most of the endometrial carcinomas that were detected by this interpretation were actually low-grade endometrioid carcinomas. So about 60% of all the endometrial carcinomas that were found were low-grade endometrioid, and most of the endometrial carcinomas, around 70%, were low-stage endometrial carcinomas. So I would think that their morphologic features were not that evident on cytology to be classified as adenocarcinomas outright. And importantly, there was only one HPV-associated glandular lesion, that is AIS, that was HPV negative in this cohort. Next slide. So as I had mentioned before, we looked at the clinical history of the patients that were found to have significant histologic outcomes. And for this particular investigation, we subdivided them into patients with HPV-associated lesions and patients with HPV-independent lesions. So now we have 53 patients because we added that one patient with AIS in this subgroup. And, as one may understand, because, these lesions are associated with persistent HPV infection, when we look deeper into the electronic medical record, as many as 81% of these patients had documented prior abnormal history. And that history could have been in the form of abnormal cytology, a positive HPV test, abnormal histology, and in some patients, the abnormal history was not further specified. And some patients may have had a combination of more than one. So only 10 patients had negative or unknown history in this subgroup. Next slide. Now, if we look at the HPV-independent lesions, most of which I have already elaborated upon, were endometrial carcinomas. As many as 91% of patients had signs and symptoms or actually an established diagnosis at the time of the Pap test. So as many as 44% of patients with endometrial carcinoma had no diagnosis of endometrial cancer. And in many instances, it was a concurrent Pap and a concurrent biopsy. So the PAP is somewhat signed out at the same time, and one obviously thinks that the PAP test interpretation may have been influenced by the biopsy interpretation. And there were only 5 patients, or about 10% patients in this subgroup, which had no documented significant history. Next slide, please.
So what are the, so here, I like to ask, what are the limitations of your study? Because any study, regardless of how innovative and well-designed they are, has limitations due to cost and resource constraints. So can you talk a little bit about the limitations regarding this study?
Right. When we think about cervical cancer screening, we have to think about it with regard to different populations and, on a larger scale. But the most significant limitation of this study is that this is a single institution-based study, so it doesn't reflect practice patterns on a larger scale. And therefore, in light of that, it is still a limited data set. And we only had rare cases of HPV-associated cancer that were proven histologically, so that is also a limitation. We cannot comment regarding the role of cytology in the detection of those cancers. Also, this was a retrospective study, so there was variability in how the patients were followed. And the HPV testing platforms that were used during this period at our institution, that is Optima and hybrid capture tube, they are not currently FDA approved for the purposes of primary HPV testing.
Now, Dr. Goyal, before we get to get to your thoughts on the future of cervical cancer screening and concluding remarks, I wanted to ask you if there were anything from the study findings that surprised you. Sometimes study results are not what you had expected. Were there anything from the findings that surprised you?
Yeah, I think, as I mentioned, the endometrial carcinomas that were detected in our study, most of them were low-grade endometrioid carcinomas, and many of them were low stage. And this is in striking contrast to what has been published in the literature. It seems that those cancers, they generally tend to be outright high grade or, are presenting at a more advanced stage. And I kind of concluded that this may be related to the practice pattern at our institution, where the cancers that are high grade or are clinically obvious or at an advanced stage, maybe those patients are not undergoing a PAP test for their clinical workup. And another finding, which I will not say surprising, but somewhat illuminating, because I think it has been understudied, is how these patients with HPV-independent lesions, how they present. So it seems like 91% already have signs and symptoms of the disease, or they already have a diagnosis when the PAP test is performed. So I think we need more data regarding the role of cytology for such HPV-independent lesions.
Wonderful. As we look to wrap up today's discussion, I would like to turn to you also to make concluding remarks. Of course, we'll open up the floor after this for feedbacks and comments from the audience. My take from reading the article is that more studies may be needed to say with certainty what the role of cytology may be in cervical cancer screening moving forward. Dr. Goyal, what's your concluding remark?
Now, as I went through the study findings, you may recollect that as many as 81% of patients who were HPV negative and were found to have high SIL or worse, they had a documented past abnormal history. Now, if we look at the trends in cervical cancer screening, there is a lot of emphasis on risk stratification. So, considering the situation where the patient is compliant with follow-up, where there is strict adherence to guidelines, where there is easy access to patient history, in that situation, primary HPV testing can be very successful. And the role of cytology will eventually get limited. It is still a valuable adjunct, but if we have all these tools incorporated in our healthcare, we can easily identify these cases which may have been potentially missed if we don't have access to past history. And as the other conclusion, as I already mentioned, that we're not exactly certain what the role of cytology is in the detection of HPV-dependent lesions, but probably it may have expedited the management of these patients.
Very good. I wanted to ask you one final question, if I can squeeze that in there. What do you think are the main issues that are important in the implementation of cervical cancer screening? And a related question, which is, if you could look into your crystal ball, looking to the future, what do you think the future of cervical cancer screening will look like?
Yeah, I think, we have to look at the distribution of cervical cancer. And it seems that even today, cervical cancer is prevalent in those populations which are never screened or who have been rarely screened. So I think for any successful cervical cancer screening program, we have to target these subsections of the population, these low resource settings. And I think we are moving in the right direction. We are looking at self-collection for the purposes of primary HPV testing, which will definitely expand the accessibility to cervical cancer screening. And then we are also looking at what are the barriers in the implementation of primary HPV screening through the Primary HPV Screening Initiative. And we're also trying to expand the coverage for HPV vaccination. And also, there are some tools in development or which have already been developed for further or for better risk stratification of patients. So I think the future looks very optimistic, and it's all that, it will require a large-scale effort from a lot of organizations, from clinicians, from pathologists, from cytologists. All of us have to work together to expand this access to cervical cancer screening.
Very good. Now we have reached the end of our presentation, and we'd like to open up the floor for questions and answers and comments, sharing. Do we have any questions from the audience through chat box?
As of right now, we do not have any. Oh, one just came up. Hang on 1 second. Thank you for that outstanding presentation. The limitation of the study you have highlighted are interesting. It seems that the study also has a great number of strengths. Among them, what would you say are the greatest strengths of your study, which is the rest of us can learn from moving forward?
Well, I don't know what you can learn from it, but I can tell you, in my opinion, what I consider are the strengths of the study. As I said, that this is a single institution-based study, but if we consider that and all the variables that we incorporated in the study, we had a reasonable cohort of patients. And we had follow-up for as many as 77% of patients within a period of 1 year. So we had a good amount of data. And also, the whole idea of the study is also its strength, that we incorporated the HPV-independent lesions. We also looked at the past history and the clinical presentation of the patients in detail, which I think has been underdocumented in the literature.
At this time, we do not have any other questions.
I have a question. Yeah. So this is very interesting study and very thorough, and also correlated. The strength of this study is, you know, the your study cohort is pretty big, and also you correlate with a histology correlation, follow-up diagnosis, biopsy, and also correlate with clinical presentation. I think all those are very unique. And for me, you know, when I read your article, the very striking information, you know, when I look at your table 1, I saw like, for example, high-grade lesion, you have like more than 9%, yeah, here, 9% of patients, they have a negative HPV test. However, when you did, you know, clinical history checkup and follow-up checkup, and among those patients, I think more than half, they already had another test, HPV positive, and also follow-up, you know, lesions. But still, I mean, still, even you take off those correlated with history, those patients already had abnormal history, but you still have certain number of patients is like true negative. So I think cytology in this point, you know, we still can contribute our expertise and diagnostic skills to help this patient. So the other interesting finding from your study, if you look so-called glandular lesion, you know, this the HPV negative test is much higher in that populations, in like, you know, glandular lesion. That's also very interesting. And as you mentioned, like those patients, most of them already had a clinical symptom, you know, and also the follow-up biopsy is low grade. I think that's important because low grade, you know, the patient had better survival rate and better prognosis. So the cytology may be still important to do clinical screening, you know, tests for those population of patients, especially, you know, abnormal bleeding in elderly patients. They are, you know, usually HPV negative. I think this is a very interesting study, very unique, and it's different than the others. Others are, you know, they purely look at the HPV negative, most of the study, and they categorize the cytology lesion. But in your study, you separated HPV-related squamous lesion and HPV-independent glandular lesion, and also did a clinical follow-up and also histology follow-up. I think that's very interesting. I learned a lot. And last question. So for this cohort, HPV test was started in 2014. Your study used kind of a different HPV test, like a hybrid, you know, capture. So do you have any idea how correlate this different tests? Are they correlated very well? I assume, right? But I didn't do the search.
Well, I have looked at the correlation of Optima with the Roche scores, and I think there is a very high degree of concordance between Optima and Roche, but I haven't looked at hybrid capture too lately.
Yeah, but what the test that you are doing now in your institute?
We still have Optima.
Okay, okay. Thank you. Thank you so much.
Thank you very much.
Okay, we've gotten a couple more questions. Even though you detected only a small number of neoplasms in the HPV cohort, have you discussed with your clinicians to order both HPV and PAP examination in the evaluation of their patients? Currently only offer both HPV and PAP testing together. Our clinicians use both results to triage their patients for future follow-up.
I'm trying to understand the question. So I guess they're asking which test is being used for patient follow-up?
It says, have you discussed with your clinicians to order both HPV and PAP examination and evaluation of their patients?
Well, right now it's up to the clinicians. And I haven't seen a declining trend in requests for cytology. You know, first of all, we are not offering an HPV testing platform that is FDA approved for primary HPV testing. And a lot of our requests are actually co-testing. So, so I haven't seen a decline in requests for cytology, and maybe one of the limitations would be that we don't have that particular platform at our institution.
Okay, another question. Is there any indication that any of the non-FDA approved HPV testing platforms would underperform and not be able to achieve FDA approval?
Well, I think the main barrier is that for a test to be able to perform in such a setting, which is demanded by primary HPV testing, one needs to show the performance to be equivalent to that test which has already been approved. And ideally, one should show that through a rigorous clinical trial. So, you know, if they are able to achieve a similar level of performance, I would think that that would perform similarly. But I think that is the challenging aspect.
One more question specifically for Dr. Choi. I noticed that in this study, there's a steady graduation in the percentages of HPV negative cases from ASCH to LCILH to HSIL. In your role as a cytologist, would you like add an LSILH category to your reporting system in order to better stratify patients by risk?
I think this is a better question for Dr. Goyal, as she is more familiar and she is the author of the study. So I would defer it to her and her expert opinion.
Well, that's an interesting question. Now, you have to understand that this study investigated data over a period of a little over 9 years, right? So that was like from September 2010 onwards. So for some point of time, during the course of the study, we were using LCILH. I think we stopped using it somewhere in 2016 after the 2014 Bethesda system came out. But you know, you bring up an interesting point. As you have noted that LCILH tends to be less HPV negative than ASCH. And currently we are using ASCH and LCIL as like, you know, a double interpretation rather than LCILH, because this category is not favored by the Bethesda reporting system of 2014. But yeah, because, you know, when there is LCIL in the sample, the patient is more likely to be HPV positive. So that's why, you know, you see a lower percentage of these interpretations as HPV negative.
And there's one more question. How many cases per 100,000 seem to be clinically important pickups in HPV negative PAP tests?
Well, yeah, that's an interesting question. So I could say that, you know, we looked at around overall for this period, there were a little over 345,000 Pap tests that were examined at our institution. So, and then, you know, you have to consider that not all of them were tested for HPV, right? So we are not going to get the exact number, but out of those that were tested, right? So I don't know if we can figure out that information from the data provided in the study, because not all patients underwent HPV testing.
And that's all the questions that have come in. So with that, I'd like to thank everyone for joining us today. And thank you both for presenting this article. Have a great day.
Thank you so much, Paul and Dr. Goyal. Learned a lot. Thank you.